Good afternoon, everybody. Thank you so much for coming to today's discussion of maternal health and HIV integration. My name is Gib Clark. I'm the coordinator of the Wilson Center's Global Health Initiative, not to be confused with another global health initiative I think you'll hear about a little later. Our program focuses on maternal health, health financing, and post-conflict, post-disaster health care delivery. So we're really excited to be having today's discussion. And we're even more exciting that today's discussion is the first of what is going to be a 9-event series between now and September, focusing on issues related to maternal health, including family planning, task shifting and human resources issues, refugee and IDP populations in maternal health, and maternal health as a key element of health system strengthening, among other events. Besides the events, we're going to have video interviews with leaders in the field, blogs, and all sorts of other content posted on our site and also those of our collaborators. And we are thrilled that we have really a great set of collaborators on this project. We're very thankful for funding from Gender Health's Maternal Health Task Force and the UNFPA. But more than the funding, the collaboration with them has been very fruitful, and as well as collaboration with USAID. So thank you to all of those folks. Unfortunately, Marianne Stanton from USAID is not here today. She's really been the driver on that bus, but she's off traveling. But I would like to recognize Sarah Craven and Anne Blank and ask that they just say a quick word.
Good afternoon. My name is Anne Blank. I'm the director of the Maternal Health Task Force at Engender Health. On behalf of the Maternal Health Task Force, I want to thank our partners in this policy dialogue series, who Gib just mentioned. One component of our mandate, for those of you who don't know about the Maternal Health Task Force, is to help identify gaps in knowledge and areas where more discussion and greater consensus is needed, and to provide opportunities for the maternal health community to convene around them. Through this upcoming series that Gib just described, we'll explore in greater depth some of the neglected issues and gaps in knowledge that have been obstacles in advancing the maternal health field. We look forward to your active participation as these dialogues convene over the next several months. I also invite you to join our online discussion of these and other maternal health topics on our website, newly launched yesterday, at www.maternalhealthtaskforce.org. Thanks again to our partners for making these dialogues possible, and thanks to all of you for coming today.
I'm Sarah Craven with UNFPA, and I just want to echo everything that Anne said and how delighted we are at the great turnout for this first event. So we hope that you'll continue to come and that we'll continue to have this dialogue both here at the Wilson Center and also in online forums as well. So thank you for coming. Thank you to the Wilson Center and the speakers, and thank you to Engender Health.
Okay, lots of thanks to go around. I'm just going to spend a second on bios. Longer bios are available outside. You may have picked them up on the way in. And even those we had to cut down a lot. So go to their websites if you want to hear all about the speakers. But quickly, I'll just say that Claudes Kamenga is a medical doctor and a public health specialist with more than 20 years of international experience in health and HIV/AIDS programming and research. As a senior director of technical support and research utilization at FHI, he provides oversight and leadership on technical support in HIV prevention, care and treatment, and on research utilization. Next, we'll hear from Michele Moloney-Kitts, who is the Assistant United States Global AIDS Coordinator in the Office of the U.S. Global AIDS Coordinator, which leads implementation of PEPFAR, the U.S. President's Emergency Plan for AIDS Relief. She is a Foreign Service officer and a nurse midwife who has worked extensively both abroad and here in the U.S. And finally, we'll hear from Harriet Birungi, who is a medical anthropologist who, for the past 9 years, has worked as an associate with the Pop Council's Reproductive Health Program. She is currently the project director on an operations research project in Kenya that supports USAID's AIDS Population and Health Integrated Assessment Program to find innovative ways to improve service delivery through research. As I said, much more information on all of them is available in the bios. A couple of things before we get started. The first is I just apologize for the tight squeeze here. We should have known better. Our maternal health events always get a big turnout, and we'll do our best to move to our auditorium upstairs in the future. For those of you watching on the overflow room, and for that matter, for those of you watching on the webcast, please write down your questions if you have any, and we'll try to work them into the Q&A following the presentations. And finally, we are webcasting this event, so I ask that when we get to the Q&A, please wait for a microphone and let us know who you are and where you're working. So I've said enough. I'll now turn things over to Claude.
Thank you. Thanks. Can you all hear me well? Yes. Thank you. I would like first to really take this opportunity to thank the organizers for associating FHI to this important event. I'm making this presentation on behalf of my colleagues, Ward Cates and Rose Wilcher, who couldn't make it because of previous commitment. I would really be preaching to the converted by trying to emphasize how maternal health is critical. But I just thought actually that I would remind us that each year there are at least 500,000 maternal deaths around the world, and all those mostly due to poor or limited access to maternal health services. You all know how important excessive bleeding occurs in the developing countries among mothers, eclampsia, infections, obstructive labor, and also unsafe abortion. So this meeting and this event can be really appreciated in terms of the process that we will be, as Gibbs said, going through in the next few weeks. I will be talking about integration really based on our experience in family planning and HIV integration, recognizing that family planning is an important subset in our broader effort in integrating reproductive health and HIV programs. In the next 19 minutes or so, what I'm going to try to do is attempt to define integration, recognizing that it can actually be defined in 1,000 different ways. So I will just share one definition that I have seen, at least from WHO and many of the organizations represented in this room. I will then try to share some rationale or arguments in support for integration. And lastly, I will try to share some opportunities and challenges for integration. So what do we mean by integration? Integration is how different services or operational programs can be joined with the aim to maximize collective outcomes. It's based on the need to offer comprehensive services. In practical terms, what that means is organizing and providing a range of services that meet several needs simultaneously, and where provider screen clients for unmet needs, not only focus on a condition but focus on the individual to address many other needs that they may have, rather than focusing on testing for HIV or responding to a specific need that brought that individual to your clinic. It also means providing services only to those clients who need them, not forcing services on clients. And lastly, it would also mean that these services are organized either as fully integrated, where all services are provided on the same spot, or where some of the services are provided through referral. Now, I think many of you have been in the field supervising or just visiting HIV programs, especially PMTCT, where a few years back you would actually see, in a setting where syphilis might actually be more prevalent, but women are not tested for syphilis, but tested for HIV, and you are told that the funding you have is only for HIV, but not actually to address that other need. So that is what we're talking about when it comes to really integrating services. So why do we integrate in the first place? There are many fine reasons why we should integrate. I think I wouldn't be mistaken to say that all of you in this room have at least once taken your car for servicing. I'm sure you would be very disappointed if your mechanic tells you, I can only fix the left tire, but for the right one you need to go to that other shop. So we do integrate because clients seeking HIV services and those seeking reproductive health services often share common needs. As shown on the slide, these people often are both sexually active and of reproductive age. They are at risk of HIV infection or might be already infected. They need access to contraceptives and also need to know how HIV affects contraceptive options and vice versa. Protecting the health and human rights of women by enabling them to prevent unintended pregnancies is a long-established goal that remains unrealized in many parts of the world where all of us work. Of course, not all HIV-infected women want to postpone childbearing, but they have a right to appropriate counseling in order to make informed reproductive choices. On the other hand, many clients using reproductive health services are sexually active and may be at risk of acquiring HIV or are already HIV infected. Regardless of HIV status, we all know about the benefit of family planning for women. Indeed, family planning delays first births, lengthens birth intervals, reduces the total number of children born to one woman, prevents high-risk and unintended pregnancies, and reduces the need for unsafe abortion. And through these mechanisms, family planning reduces maternal mortality and also infant mortality. Contraception is HIV prevention. Without increasing access to family planning, the UNGA's goal of reducing the proportion of infected children by 50% by next year actually cannot be achieved. Even moderate decreases in unintended pregnancies to HIV-positive women will reduce same number of HIV-positive births as current PMTC programs do. So this slide shows you the 4 prongs of PMTCT strategy. As we all know, preventing unintended pregnancy is one of the most important way of preventing transmission from mother to child, as shown on this slide. Traditionally, however, our efforts have focused on the 3rd prong, which deals with HIV-positive women who are pregnant, neglecting the first 2 prongs, which together would actually prevent more infections. And through our PMTC effort, we have actually several opportunities for integration by introducing sexual and reproductive health intervention in all these steps in our strategy. Pregnancies are often unintended or unwanted. As you can see from this slide, ranging from as low as 5% all the way to 60%. Women with HIV also have unintended pregnancies. Although there's not much information about the level of unintended pregnancies among HIV-positive women, there are some studies that have actually suggested that these levels can be quite high. A study by Rochard and al. Documented a 84% unintended pregnancy rate among PMTCT clients in South Africa. Another study in Rwanda documented 70% unintended pregnancy among women in art program in Rwanda. And lastly, 85% of women in Malawi who learned their HIV status reported desiring not to have more children. So, what are the effects of current contraceptive use by HIV-positive women? Using DHS surveys as the basis for estimate, the following assumptions have been used to estimate what the effect of contraceptive use in HIV-positive women would be, assuming an average of 15% of women in sub-Saharan Africa using effective contraceptive, which is quite optimistic to some extent. 7.8 million unintended births averted by contraception, and an average HIV prevalence in sub-Saharan Africa of 7.4. So, as shown on this slide, comparing contraception and PMTCT programs as we know them, effective contraception would actually prevent at least 2.5 times more infection from mothers to their children than would a common PMTCT program do. 220 HIV infection averted in 1 year versus 86 infections averted in that same period through our normal PMTCT programs. So contraception is really the best kept secret in HIV prevention. Effective contraception for HIV positive women who do not wish to become pregnant prevent more infants from becoming infected, decreases the number of future orphans. It's a cost-effective HIV prevention intervention. And the quick question that remains for us is how best to achieve reproductive health and HIV integration. Let's now look at opportunities and challenges for reproductive health and HIV integration. I will try to discuss these at 3 levels. At the international level, I'm going to look at policies and funding trends. At the country level, look at Ministry of Health structures and other coordinating bodies. And at service delivery level, look at how the operationalization of reproductive health and HIV linkages can be made real. At international level, we have some opportunities. Within the last few years, several major international agencies have issued statements in support of integration of sexual and reproductive health and HIV services, including the Glion Call to Action on Family Planning and HIV in Women and Children, which was issued in 2004, the New York Call to Commitment on Linking HIV and Sexual and Reproductive Health in 2005, and the Maputo Plan of Action on Policy Framework for Sexual and Reproductive Health and Right. In addition, just a couple of days ago in his Jonathan Mann Memorial Lecture, Ambassador Gusby underscored the need for strategic integration of care services such as maternal and child health and family planning with HIV, in line with the President Obama's Global Health Initiative, which Michele will probably shed some light in the next few minutes. Still on opportunities, as part of the Global Fund, sexual and reproductive health components are now being more and more advocated for, and funds from the Global Fund can now be used to purchase commodities for family planning and reproductive health. As part of PEPFAR, Prevention for Positive allows for providing reproductive health services for those with HIV infection. And also the new COPE, the Country Operating Plan guidance, encourages integration of HIV and reproductive health. There are a few challenges at the international level, which I have already mentioned before. International donors' funding lacks family planning indicators. And as you know, what gets measured gets done. If it's not measured, it was not done. So that is a big challenge that we need to address. In addition, PMTCT programs continue to be mostly focused on antiretroviral prophylaxis, which is a very big missed opportunity. At the country level, you all have certainly more information that I might have, but there's clearly emerging policy support at the country level with strategy for the integration of family planning and VCT services in Kenya, for example. High priority family planning strategies being developed, examples from Mozambique and Rwanda. There are country-specific technical working groups on sexual and reproductive health and HIV integration being established. And also there's an increasing number of integrated SRH HIV bilateral programs. For example, Kenya, Nigeria, Zimbabwe, and for those of you familiar with West Africa, as you certainly know, the Action for West Africa region, which used to have two separate projects, one on HIV, the other on reproductive health, has now been actually combined in one integrated project. So that shows that there's really things happening at the country level. Some challenges at the country level which are quite obvious is parallel RH and HIV department and funding within the ministries of health in several countries where we work. Lack of policies, guidelines, and training programs for integrated RH and HIV services. Limited coordination between departments, and the usual turf issues that we are not stranger to. At the service delivery level, there are some very good opportunities. The unmet needs for family planning and high level of unintended pregnancy among clients of HIV services is well documented, as I just presented a few minutes ago. Integrated services are acceptable to HIV providers and clients. And integrated services do not appear to negatively affect the quality of the basic services, whether counseling and testing, PMTCT, or other HIV services. But of course, there are still many challenges at the delivery point. Various operational considerations, including commodities and logistics, human resource capacity, supervision, reporting, referral system, and community involvement in service delivery. We need also to address family planning provider biases and preparedness to serve HIV positive clients, which seem to continue to be a problem. So as we move forward, I believe that the question to us shouldn't be if, but rather how best to achieve integration. We need to use the growing evidence base and available tools to support integration programming. We need to go beyond service delivery level to address integration from the policy level all the way to the community. Finally, we need to seize the momentum in policy change at the global level to advance reproductive health and HIV integration if we are to make significant progress on the Millennium Development Goals in the developing countries. With that, I will stop and thank you for your attention.
Okay, we're going to save all questions for the end, so we're just going to turn things right over to Michele.
I need my glasses. Everybody can hear me okay? Well, first of all, thank you very much for inviting me and to my co-panelists. And what I'm going to do today is basically talk a little bit about kind of where we are and why this is important, some recent PEPFAR results, kind of integration of HIV and maternal health services, reproductive health services. What are some of the opportunities in PEPFAR? We have a couple good experiences that I'd like to share with you, and then what are some of the things that we're facing moving forward. So this is an audience of the converted, but I think that we have, as my colleague just mentioned, some very good new data recently in our armamentarium. And for those of you who haven't looked at it, I strongly encourage you to look at the new WHO report. There's some very, very important data in there about the status of women's health, and really does help us in terms of thinking about our agenda moving forward. Most of you are quite familiar with this data, but I think there were some things in there that are highlighted that maybe people are less aware of. And the one that I'd like to point out is that women who are HIV infected have maternal mortality rates that are 5 times higher than non-infected women. So as we look at safe motherhood initiatives and moving forward, I think that we have to recognize that HIV positive women are a very important part of this cohort. And I do get a little bit worried about an HIV versus maternal mortality divide. And I think that we have to look at this rather as we did, health system strengthening versus vertical infectious disease programs as something that really affects women and populations and health moving forward, and that we have to really come together around a cohesive approach. Some key data, and because it's quite around near World AIDS Day, we have the most recent PEPFAR results that I thought I would just take the opportunity to share with you, because in fact these do fit quite closely into the directions we're headed in and impact on maternal health and maternal mortality. So I think, as many of you may be aware, we now have over 2.4 million people receiving treatment directly from PEPFAR. Overall, it's over 4 million now, and that we have more than 11 million people in care, including over 3.6 million orphans. And when you think about that, that's a lot of opportunity for integration. Ditto on the counseling and testing, and I think when you think that 29 million people have been counseled and tested with PEPFAR funding, and then, as we mentioned, prevention to mother-to-child transmission. Looking forward, it's important to note that we've also recently released our strategy, and we're now going to be scaling up treatment to more than 4 million people. So again, lots of opportunity there. So how are we doing so far in terms of reaching women? Well, I think PEPFAR is doing pretty well. In fact, in terms of treatment, one of the issues I think that many of us are dealing with is that we should be doing a little bit better with men. And in fact, the fact that we have so many more women on treatment isn't necessarily a sign that women are more infected if you look across total age cohorts, but rather that women go to health centers for one reason or another, but men often prefer other locales. And in fact, we have some very interesting work underway where we're looking at where men like to get services, because we know they don't want to go to a primary health care center. And for those of us who have men in our lives, I think we've all had that experience. So we're experimenting actually with post office. Apparently they do like to go pick up the mail. But I mean, all joking aside, it is an important number and something we have to look to forward. Also, I did want to just highlight that PEPFAR is doing pretty well on the condom front, including female condoms, although, again, I think female condoms we all recognize would be an opportunity moving forward. This slide is too small for you to see, for which I apologize, but basically the point here is to look at the progress we're making in PMTCT, and we are making some real progress. I think Botswana is a very stellar example for those of you who know the program. Somebody told me there was a laser pointer with this thing, but probably... Okay. So this slide over here is basically what actually we care most about, which is how many women are actually not only tested and identified as HIV positive, but then receive treatment. And as you can see, we're making headway. The yellow line is 2007, and the blue line is 2008. No, it's the other way around. Sorry, blue is 2008. Yellow is 2008. But we still have an incredibly long way to go. And what you can't read down here are which these countries are, and it's all pretty predictable. The very bottom one, I believe, is Cote d'Ivoire. So what are our opportunities in terms of putting things together? We did have a mention of the Global Health Initiative, and I think looking forward under the Obama administration, this is going to be our focus. It was announced, excuse me, by President Obama in May, and it's a $63 billion commitment over a 6-year time frame. And basically, there are some very important principles moving forward that really look to say that people's health in developing countries is not one specific disease. It's a multitude. We have TB, we have HIV, we have malaria, we have maternal mortality, we have neglected tropical diseases. There's a range of things, and we need to really focus on this more integrated approach. It also looks at a number of other elements that cross-cut that we want to apply a much stronger lens on moving forward. Country ownership being very key, increasing capacity in health systems along the way to lend itself to more sustainable approaches. Looking at stronger multilateral engagements. We're not alone. The U.S. is the largest donor in the sector, but we have a lot of other players and partners, and we have to coordinate better. And very central to the Global Health Initiative is putting women at the center of care. In terms of family planning, I think we've had a great presentation about why it's very important. You know, women with HIV, like any women anywhere, they have the right to determine the number and spacing of their children. We've heard a lot about their unmet need for contraception, and we do know that there are a lot of women who are HIV positive or who don't know their HIV status, who really do have an unmet need for contraception. And there's a lot of opportunity to expand their access and improve their quality of life and prevent unintended pregnancies. I do want to pause for a moment, though, because we are quite concerned about another issue, which is that a number of women who are HIV positive really want to have another child, and they should have the right to do that the same as any other woman, and they should have the opportunity to be registered into care. And we now have, and again, going back to Botswana, transmission rates of HIV for mother-to-child transmission in a country that has a robust PMTCT program are actually almost as low as we have in the U.S. because the only intervention that they're really missing is cesarean section. So I think it's very important going forward, and I've seen a number of materials recently that have really disturbed me about, for example, commitments to mother-to-mother peer education programs where to be a volunteer in those programs you have to commit to having no more children. I mean, things like that which are really, everybody needs to be ever vigilant about. In terms of guidance on linkages, PEPFAR is really trying to have much more robust guidance. And I want to highlight something on this slide, and if I could have bolded it, I went back and I forgot. Where feasible and appropriate. I think this is hugely important. We have a lot of experience, for those of you who are older like me, where, I mean, there was a day where we really wanted every family planning client to have access to diagnostics and treatment for STIs. And we spent a huge amount of money trying to integrate STI treatment into family planning clinics without really looking at what is the prevalence of STIs in those populations. Does it really make sense? Is it a cost-effective intervention? If we go and say counseling and testing, should every woman in, I don't know, Bangladesh have access to counseling and testing for HIV? You know, in a perfect world, absolutely. But in a real world where you have cost constraints, and many things, I think we have to really tailor our response to the epidemic. So you have to really know what your data is. But assuming that the data indicates that this is the appropriate way to go, obviously we need to look at platforms of antenatal care and pregnancy care and child primary health care centers basically is an excellent platform to consider linking with PMTCT programs. We need to look at how we can do better with family planning. For those of you who've heard me speak before, you know I'm a big fan of co-locating programs. I think it makes one-stop shopping, you know, as we heard about the left and right tire, makes perfect sense. And training family planning providers provides a lot of opportunity. My current soapbox has to do with emergency obstetric care and neonatal resuscitation. Anytime we train a healthcare provider who reaches women on a regular basis, I just don't understand why we're not adding this component to their training. It could save so many lives. And of course, we need to look at linkages with other programs that are there, like malaria. Also, I do want to highlight that PMTCT is very important to us moving forward, and we're looking quite closely at, there's a couple of countries where we feel as though the opportunity is ripe for us to really bring PMTCT programs to scale, and we do feel as though it's a very, very important and missed opportunity and needs a lot of focus. Bolstering primary prevention. This was, I think, my colleague made a very important and significant case for this. And again, thinking about pregnant women themselves, they're twice as likely to be infected with HIV while they're pregnant. We have very high partner discordance rates, and we think that involving men in the antenatal care period is extremely important as well. The whole idea of what we're calling prevention with positives, but hopefully preventing you needing to do a prevention with positives, so that if you can really engage men in prenatal care, antenatal care, moving forward can be very helpful. One thing that I think in PEPFAR we're particularly proud of is that I think we've broken kind of a major barrier in development where working with cervical cancer, considering cervical cancer was really a no-go zone in the family planning arena for forever. And however, when you're dealing with HIV-positive women, cervical cancer is a huge issue for them. And so we now have actually a very robust program. The science is being advanced in terms of basically how to do cancer detection and treatment in low resource settings, and we're now reaching a number of women in very important ways, and that's actually one of my examples a little bit later. You can't talk about integrating reproductive and sexual health without considering a broader and more robust gender element to what we're talking about, and certainly as we move forward in PEPFAR, gender will be increasingly important. As you know, we've been pretty much focused on 5 major cross-cutting strategies: gender equity in our activities, reducing violence and coercion, addressing male norms, legal rights, and resources. And this will really continue into the future. And I want to show you an example of why this is so important. And it also gets to the fact that we do much more than public health. We have to kind of look at the structural situation and context that people are living and working in. This is incidence data, and I will put a little caveat. This is based on incidence marker using detuned assays, which is not 100% reliable in all honesty, but it was the best we have. But the thing that's so important about this slide is that it's looking at South Africans, girls in across this time frame, and this is their incidence by age. The ages are running across the bottom. Now, that looks like a pretty powerful prevention interventions have happened across those 3 years, or across that time frame. And basically, this is when South Africa introduced very robust life skills training into their schools. And though we're actually going back now and trying to do some deeper analysis of this data to figure out what exactly helped get us there, it shows one of the reasons why it's so important that we look at women and girls from a broader aspect. Also, I want to just note that we are very concerned with the relationship between gender-based violence and HIV. We think that it's very important to have a very robust response to gender-based violence, and I'm happy to talk about that a little bit later, but I'm worried about my time. So quick highlights of where we feel like we have pretty strong integrated approaches and models to build on as we're moving forward. One is in South Africa, where I think everybody knows South Africa has an extremely robust national family planning program. And PEPFAR is working hand in hand with that program to make sure that, in fact, when a woman comes in for care, she does get really comprehensive care with the contraceptives provided through the government national program. And they do look at dual methods there. Another successful program, which I'm sure many of you maybe have even worked on, is the AFIA project in Kenya, where basically that project is a great model because it's managed to overcome some of the policy issues related to funding streams. Because basically they've combined funding streams in this project so that it really does become a one-stop shop for women and children coming in. They have HIV funding, they have family planning funding, they have child survival funding, they have TB and malaria. So basically the provider doesn't have anything to do with where the money's coming from or what the service is. That's handled at a totally different level, but then everybody gets what they need. And as you can see, the AFIA project shows quite compellingly that when you do offer family planning services on site with HIV services, you actually have a huge uptake in family planning use. I spoke a little bit about cervical cancer. I'm sorry, this slide is way too packed, but the bottom line is that we now have cervical cancer programs for treat and screen in over 9 countries. Over 20,000 women in Zambia have been screened for cervical cancer, and then close to 20% of them actually underwent cryotherapy. So we've actually shown that in low resource settings with very low cost, we're able to introduce this incredibly critical service. So where are we headed with PEPFAR? There are some key concepts in the next phase of PEPFAR that I did want to just spend a few minutes on. These are available on our website as our strategy has been launched. But the first is really to consider how we're going to transition from an emergency response to really promoting much more sustainable programs over the long haul. And part of that will be how we strengthen the government's ability to really take ownership of their programs, manage, direct, lead, implement, evaluate, so that they can really be in charge of the response over the long term. Obviously, we need to expand prevention, care, and treatment in both concentrated and generalized epidemics. I mean, we saw a lot of good news on World AIDS Day. We also saw a lot of not so good news. So this story is far from over, and we have a lot left to do. We need to work hard on integrating and coordinating programs across board, more broadly across global health and also with development, looking at how we're going to work with health systems. And we need to do better in investing in innovations and operations research. So quite specifically, in this area of integration, there are some investment changes that you're going to see. We have set ourselves some extraordinarily ambitious targets in terms of PMTCT. also in terms of reaching children who are infected, and we very much want to expand our ability to integrate services at the primary health care and below and above, actually, level, so that basically, regardless, you can walk in and get your services that you need. We're also really going to be working harder on the linkages with development more broadly, and particularly the tie-in with food, nutrition, education, and livelihood support, as well as I said, very focused on gender. We just think that this issue of gender, we've talked about it in the HIV community for a long time, and it's really, I think, everything is coming together, and this is the time, and we're going to be able to make some real progress. That being said, whoops. My slides got reversed. So I'm going to go back and forth. So obviously we face some real challenges. I think, in all honesty, we like integration because it intuitively feels like the right thing to do, and largely because of our own personal experiences in seeking services as well as our working communities. But we really don't have a lot of research out there in terms of what are the optimal ways to do it, what is the actual cost going to be, what are the best platforms to expand off of. We know, for example, in some places HIV is highly stigmatized. Do you integrate it in? Do you leave it apart? I mean, there's a lot of questions we have to ask, including the bias of providers, and I thought that was a really great point. We have to overcome these various funding challenges, streams, and different policies. We hope that this will get better, but it is kind of a fact of life, and at least in the U.S. government, and something that we're working on. And then we have to have better indicators to look at, to really, as, again, my colleagues stated, how are we doing this? How can we move? We've got to be able to measure it effectively. Sorry. But there's also huge opportunities. And I just pull up, this is a map, and again, it's not easy to read, but basically what this does is it basically looks at where the service delivery sites are. There's over 1,500 PMTCT service delivery sites in Tanzania. These are largely within the public health system. And that right there is an amazing platform to reach many, many people and to save many, many lives. And I think this is where we're kind of conceptually trying to come from. So in conclusion, we've made a lot of headway, and we're making steps towards better and more integrated programs. We think the Global Health Initiative provides exactly the leverage, the opportunity, and the platform for us to do this over the next coming years. And we'll also have to not just think about the service itself, but what surrounds it. So we know, for example, that there are a lot of barriers to women accessing services that go beyond the actual availability of the clinic. And they actually start with the education of those young girls that I showed in the data slide I had earlier from South Africa. So we really do need this comprehensive and robust approach. And this little girl thanks you.
Okay, thank you very much. We'll turn it over to Harriet.
Thank you all. Thank you for making the meeting possible. My presentation is about expanding access to reproductive health and maternal health services for adolescent girls living with HIV. I also would like to bring attention to young people who are born with HIV/AIDS who are now maturing into adolescents and adults. I do this by drawing on the work that Population Council, together with local partners in Kenya and Uganda, has been undertaking since 2007, where we've had a chance to interact with around 1,000 young people who are born with HIV/AIDS and their counselors. Generally, I think there's been a very false assumption that adolescence is an age which is HIV-free. And yet, when you look at DHS data, you find that prevalence of HIV among adolescents is quite high in the Africa region, with levels ranging between 2.6% in Uganda to around 10% in Swaziland among adolescent girls. And yet, for most programming, we only talk about children affected by HIV. Increasingly, we are beginning to talk about children infected with HIV within this range of age group. But hardly do we have programs that are really targeting this population. The HIV prevalence within this age group is quite high because we know that there's early age at first sex within the region. There's also very high unsafe sex. And there's also early marriages, and also still we have very high vertical transmission for HIV because PMCTC programs still remain ineffective within the region. In East Africa and elsewhere in Sub-Saharan Africa, pediatric HIV care is high on the agenda of most programs. And because of ART medications, the proportion of children perinatally infected with HIV who live on into adolescence is rapidly increasing. And with many of them seeking to become sexually active and even to have children. Unfortunately, what is least talked about or addressed is the social aspects of lives of children with HIV, and later on as adolescents facing challenges of relationships and of sexuality while they are living with HIV. HIV-positive adolescents face additional challenges. One of the major challenges is that RH and maternal health services in many of our countries are not adolescent-friendly. The situation becomes even more complex in the case of adolescents living with HIV. Because being HIV positive is an additional source of discrimination, providers might not respect the rights to intimacy, to love, and to have children for this type of children. And often service providers seem neither interested or motivated or prepared to find out about young people's reproductive health desires and intentions and experiences. We also note that many of these young people face some difficulties. 67% of the young people that we've been following in our cohort have lost both parents, and about 30% of these children are excluded from the schooling system because parents or families that took them on thought that they were going to die, so they saw no reason for them to remain in school. So generally, outside the school environment, it's difficult to make appropriate friends, and they are often outside the protective environment and vulnerable to sexual advances and unwanted pregnancies. And they often end up as single parents, which complicates their lives further. The studies that we've done in Kenya and Uganda bring out a couple of new needs that we want to highlight upon. The Ugandan study was carried out in 2007, and we followed a cohort of 732 adolescents, and 64% of them are females, which really reflects the number of females that are receiving ART. In Kenya, the study started in 2009, and it's still ongoing, so we've just done some preliminary analysis for the presentation here, and 66% of them are females. Generally, the objectives of the study was to assess the sexual and reproductive health needs of these adolescents, and also to identify interventions that integrate these needs into existing HIV/AIDS programs. Most of the participants were identified through the HIV/AIDS programs, and over 90% are receiving ART. And we gathered our information through structured interviews, focus group discussions, and key informant interviews, and mainly asked data on access to sexual and reproductive health information and support services, on sexual and reproductive health experiences and intentions, use of maternal health services. This was something that we brought in Kenya because we realized that the population in Uganda, many of them had already been pregnant, and we had excluded a question on that. We also asked on issues of self-esteem, worries, and fears in life. So what does our data generally show? Generally, when we started doing this work, a lot of service providers did not really think that there was a lot of sexuality happening within this age group. But what we discovered is that a lot of these young people are playful, they desire to love and to be loved, and 37% in Uganda and 69% in Kenya have ever dated and see no reason not to date. Generally, HIV-positive adolescents are sexually active, and I'm not saying that they're much different from other young people who are growing up. They also want to explore their sexuality. In Kenya, we saw that many of the young people who are living with HIV/AIDS are extremely sexually active. 61% of our sample have ever had sexual intercourse. In Uganda, 31% have ever had sexual intercourse. The challenge is that a lot of this sexual activity is not protected, because when we looked at use of preventive methods at first sexual encounter, only 38% in Uganda had used a method, and only 22% had used a method in Kenya. Current use of a modern contraception is also low, 41% in Uganda and 48% in Kenya. Those currently using a condom, the figures were also equally low, but also we have to note that condom use is quite inconsistent among this population. Would have wanted to compare a little bit this data with the DHS data, but we couldn't access the Kenya DHS data because it just ended. The results are just preliminary, so it was not possible. We couldn't just compare this with the data set which was carried out 7 years ago. The HIV data for Uganda is not accessible, so we couldn't really compare this with the general population. The consequence has been high pregnancy rates, and many of them are very unintended. In Kenya, we're seeing that 64% of the sexually active young girls have ever been pregnant. And in Uganda, 41% of the sexually active young girls have ever been pregnant. On average, an HIV-positive girl who has ever had sex has been pregnant slightly more than once. And this is the age group 15 to 19. We didn't ask a question on whether the pregnancy was intended or intended for Uganda, but in Kenya, where the question was included, we found that 71% of these pregnancies were unintended. Pregnancies that resulted into a live birth were fortunately high. That was 73% for Uganda and 83% for Kenya. A lot of young people also reported to have ended the pregnancy, and this was 20% in Uganda and 12% in Kenya. We didn't ask whether it was unsafe abortion or safe abortion, but what came out of the result is that 20% of these pregnancies were terminated and 12% were terminated in Kenya. So what kind of maternal health services exist for this group? One of the things that we asked on issues of self-esteem and fear, we asked whether these young people, what was the most worrying situation in their lives. And surprisingly, normally you'd think that many of these young people are so scared for their lives because they're HIV positive, but that was not the case. 80% of them said they were very worried about being pregnant. And that was their biggest worry. Their biggest worry was not about being HIV positive. They said this is a condition they've lived with for the rest of their life, but they were really worried about being pregnant. And we realized that pregnancy creates a lot of very hard circumstances for these young people. In Kenya, we asked a little bit about use of maternal services. And what we discovered that this is still low. We asked whether they had received antenatal care services for those who had been pregnant, and only 76 had at least made one antenatal care visit. And this is much lower than the national picture, where almost like 90% of the pregnant women at least make one antenatal care visit. And just only close to a half received PMCTC services at least once. And this is a population which is known already that they're HIV positive. Good enough, at least we're seeing very high rates of delivery made at a health facility, which is higher than the national average in the general population. This is 65%. And many of the young people at least went back. They were very much interested in having a positive outcome. They didn't want their babies to be positive, so at least they went back to the well baby clinic, and 69% of the young people took back their babies for testing. Use of contraception after delivery was 43%. This is still low because we see a lot of unwanted pregnancies within this age group. We looked a little bit on surviving children, and what we discovered is that in Uganda, 67% of female respondents who had ever been pregnant have at least one living child. The figures for Kenya are slightly higher, that's 81%. What we're seeing is that even if the children are surviving, we still have very high unacceptable levels of HIV-positive infants by these respondents. For those who had at least taken their babies for testing, 21% of the infants were HIV positive, which was really sad. What we realized is that if maybe they had obtained PMCTC, maybe the levels of HIV positive infancy would have been lower. Next. Generally, what we noticed is that our data from Kenya certainly supports the importance of PMCTC. We noted that mothers who had attended PMCTC are much more likely to have an HIV-negative baby. However, as shown in the data that I've already presented, there were only 52% of these young women who had attended PMCTC. So it would be really useful to ensure that PMCTC services are scaled up for this population. So what are the opportunities for integration? There is a lot of opportunity for integration for this particular group. One of the good opportunity is that most of the HIV-positive adolescents are receiving ART, and they visit clinics regularly. So there is opportunity to systematically screen them for their sexual and reproductive health needs for information and services. The potential impact here is that we're likely to expand access to contraceptive information and services for sexually active HIV-positive adolescents. But also, if they are screened early, we are able to identify those who are pregnant and who may be requiring other critical MCH services like PMCTC, malaria, prevention of malaria and pregnancy, and also postpartum family planning. One of the challenges is how to get counselors to respect the sexual and reproductive health rights of HIV-positive adolescents. Generally, counselors have fallen into the trap of presuming that HIV prevention and sexual health promotion is mutually exclusive phenomena. We see wide program gaps at the clinics. We find that even when HIV/AIDS has become a chronic illness, counseling continues to be framed around fear, risk, and death. And this generally has tended to deny the positive life sought by adolescents and who are deserving of the support to ensure their sexual well-being and their recognition for the need to have meaningful relationships and parenthood. Counseling is never really responsive to the needs. What we normally discovered at the counseling session is that the counselors are often talking to young people and not discussing their feelings. And many of the young people that we talked to already thanked us so much for letting us listen to them and talking to them. A lot of counseling is not comprehensive. There's a lot of censoring of information. Information is about warnings against sex, information about warnings on relationships. And sometimes, even when the child is matured, the counselors often talk to the parent and guardian, even when the child is in the counseling session, and is almost focused on adherence to ART, and they're not really interested in finding out about the sexuality of the young person. And then also counseling only focuses on responsibility, but not on rights and the lives of the young person. So in this kind of situation, you find that many of the adolescents are rather hesitant to discuss their sexual behavior with the service providers. So what tools can we use in this kind of situation? What we've done in Uganda is to introduce a fertility and sexuality desire assessment tool for counselors to enable them to systematically screen and refer young people appropriately. And the tool is just a one-sheet tool which includes issues on pregnancy, issues on dating, issues of love, and the kind of things that the counselors normally don't want to talk about. But by having this quick list, the counselor is able to look at these issues and start at least engaging with the young person on these issues, and then establish what kind of services this young person may require and refer them appropriately. We also have developed some counselors' guidelines on sexual and reproductive health and rights of adolescents living with HIV. These are still being tested in Uganda. But I think in 2006, Gender Health and the International Women Living with HIV developed a manual which is really quite useful for trainers and program managers. And I think if this manual was disseminated broadly and guidelines developed, it would be very useful for enabling counselors to understand what rights is all about. Because we think that rights is something that is a common knowledge to everybody, but not many of the counselors in the clinic understand rights. For the counselors, they're trying to prevent a jam. They're not really trying to promote lives of people. So it's very important that we get them to understand what rights really mean and how we can operationalize them at the program level. What program opportunities exist? I think what is really possible in this kind of setting is that it's possible to strengthen adolescent preventive information and services within the ART programs. That is, if the counselors are willing to respect the rights of young people. We also think that it's important to establish transition clinics. Generally, we know that there are a couple of boutique clinics, adolescent boutique clinics in a few countries. But in many countries, you find that HIV/AIDS is still organized around pediatric care and adult care. And when young people who are maturing go into the pediatric clinic, they are given child counseling. So it's almost impossible to talk about issues of adulthood to the child when she's being seen through the pediatric clinic. So it would be useful to create an adolescent clinic as a bridge between the pediatric and adult clinic. And where interventions have worked, I think it would be good to consider scaling up some of these interventions. We think that it's important to create effective linkages between HIV/AIDS centers and maternal and child health clinics. When I've talked to counselors and service providers in Uganda, they say they don't want to provide PMCTC services in the HIV treatment centers. And they're extremely very worried because if you introduce PMCTC services within the HIV centers, then they say that young people will come and they would want to be delivered at the ART centers, and they don't want to carry that burden. So I think it's important to start creating effective linkages with maternal and child health clinics so that young people can be referred effectively and receive the needed services. It's also very important to sensitize service providers on the needs of HIV-positive adolescents, and also to emphasize that these young people are no different from any other young boy or girl who is growing up. And finally, I would like to say that we can only have comprehensive information and services to adolescents living with HIV if service providers begin to respect the rights of these young people. We cannot talk about integration if service providers are not respecting the rights of young people. Thank you.
Okay, thank you all very much for those three great presentations. As I said at the beginning, we're putting this on video, broadcasting it over webcast, so please wait around for a microphone when you're called on. Who wants to kick us off with questions? Up here in the front, Dan.
Hi, thank you. I'm Jill Gay, and I co-authored with Karen Hardy a guide to integration through Population Action International, and I'm a consultant with Open Society Institute. My question is, how can we increase postpartum care where much of maternal mortality takes place, and at the same time increase postpartum family planning? It seems to me that the immediate postpartum area is largely neglected, and including the issues around breastfeeding, infant feeding, etc.
We're going to take a few questions. There was one way in the back there, Kim.
My name is Doyin Oluwole. I'm the Director of Africa's Health in 2010 at AED. My question is to Dr. Kamenga. In discussing the opportunities that exist, you looked at two different levels, or three: international, country, and service delivery. I see that you omitted the regional level, and knowing in particular that we have regional institutions like the West African Health Organization, the East Central Southern African Health Community, and even WHO Regional Office for Africa, who have regional mandates and have access to ministers of health. I think this is a very huge opportunity of bringing subsets of countries together and working with them in a way that would help to move the agenda forward at country level. Also, based on your experience, having worked on a regional project, what are your thoughts about this?
Why don't we take those two? Do you want to start with the second one? Do you want to start with that second question?
I can take the second question.
I can take
You want to take the first? Go ahead.
Do you want me to go?
Go ahead.
I think my co-panelists have some ideas on this first question, too. I certainly share your concern. I feel as though the postpartum period is definitely a lost opportunity. But one of the interesting things that I've seen actually that seems to work, which may sound a bit strange, is that if in some way a postpartum visit is linked to a critical national document, like registering your child or getting a birth certificate or something like that, that in the long run has some overarching benefits for the family and the child, actually I've seen that be a hugely successful way of getting women back into care. Now I know that that's not the case everywhere. But I do know that as we view birth registration, for example, as a really critical policy issue that we need to do more on. So that's actually an approach I've seen work quite effectively in places where before you just were struggling upstream. The second, obviously, is a quality service. So if women recognize that that the service is located near to them, that it's quality, that things that are happening there are important, and that you're looking at the mother and baby as a dyad, and there are benefits to the baby, then I think you also have a better opportunity for uptake. But it's a big issue, and it's a particularly big issue for women who do not deliver at home. Who do not deliver in a facility, excuse me.
Yeah, to the first question, actually my first suggestion would be that it's not up only to this panel actually to address that question.
Right.
I would actually love this to be an exchange. I'm sure there are more experts in this room than this panel here. But the 2 cents that I can add to the discussion is one question we need actually to ask is, where do women actually deliver? Because if women are actually delivering at home or coming to the health center after delivering at home and getting into complication, so that's already something that we need to be thinking about in terms of improving actually the use of not only antenatal care, but also delivering in health facilities. So there are several issues, and I'm sure there are more experts than me in this room that can really address your question. To the second question from my colleague, I forgot your name, but I can't agree with you enough. But I think I was just naive by putting regional and international together. But clearly there's an interest in using actually these regional platforms to actually bring countries together to actually explore these challenges together. I have seen it firsthand in West Africa, where actually when you facilitate interaction between countries, how much they are willing to share experiences and accept actually support from each other in addressing those challenges. So maybe in the next time I present, I will make sure to separate regional from international. Thanks.
Okay, who wants to go next? I think, why don't we take the 2 that are at the end of this table here?
Thank you. I'm Faria Al-Fikri, currently at the Population Reference Bureau. I came here just to hear about any case studies or any studies that really identify integration of family planning into maternal health services. And by that I mean mainly during antenatal and postnatal care. And unfortunately, there is a lack of that kind of information, I feel. And my question is directed to Anne Blanc as the director of the Maternal Task Force, whether you are aware of any case studies or any literature along that lines. Thank you.
Okay, and just across the table there.
Hi, I'm Tabitha Sripipitana. I'm with the Elizabeth Glaser Pediatric AIDS Foundation, and I want to thank all of the panelists for their presentations. And I actually just have a clarification question for Harriet Birungi. On your study looking at these adolescents, you noted that 90% of them were utilizing ART, but yet you also gave a figure about half were considered to have received PMT-CT services. I wanted to hear from you what the definition of PMT-CT services were for the study.
Okay, why don't we take one more right here.
Hi, Kwekuye Boy is my name. I work for PCI, Project Concern International. I just wanted to ask a question to Claudes Kamenga about the levels where integration can be looked at. I did not hear anybody on the panel, probably I wasn't listening well enough, about communities level. We seem to be talking more about the supply side. I mean, I think in my experience working on integration, one of the things is the willingness of the clients that we're seeing who are coming in for a particular service to want to do other things, which for them is not their immediate need. So to what extent are we mobilizing communities and trying to get their sense of the need to have these looked at the same time. I would like some thoughts on that.
Okay, why don't we start with the panel? Any reflections on those questions?
What question? I can take
any
the last
of you.
one.
Sure.
Yeah, let me take the last question from my friend Kwaku. I guess you were sleeping a little bit. But on a more serious note, I do fully agree with you. In the presentation, I did not maybe spend much time addressing the community level simply because I think I don't have enough data on that level. But if you were awake actually during the presentation, you would have actually heard me saying how it's actually important for us to look at integration beyond just service delivery, but look at it from the policy level all the way to the community. Because we tend actually just to assume that people will need integrated services. But as you rightly say, we need actually not only to understand where they're coming from, but also learn from them how they would actually want to see these services provided to them, and also educate the communities for them to be active players in whole that process. So I can only agree on the need actually for us to do more at the community level if we really hope to make significant progress. I think the two other questions, one was specifically addressed to...
Harriet, did you want to?
Yeah. 90% of the children are on ART because this the population that we're focusing on are children who are born with HIV, and they've been through the ART clinic. But then when they become pregnant, of course, they have to be referred to maternal and child health services, and where they're supposed to receive comprehensive PMCTC services, including counseling on breastfeeding, family planning use, and birth planning, and also to be encouraged to deliver at a clinic. So that's what I really meant by PMCTC services, even if they are on ART as well.
Okay, and there was a question posed to Anne. It should be on.
Is this on? Okay. Thank you for the question, which I wasn't expecting. Well, we've all been in health facilities where there are large lines of women waiting for antenatal care over here and large lines of women waiting for family planning over here, right? And it seems the most natural thing in the world that those services should be integrated. So I thank you for identifying a topic that clearly needs more discussion and more research. I'm not aware of, I'm sure there is some research, and I urge you to have a look at our new website, www.maternalhealthtaskforce.org, where we have a dedicated search engine for maternal health materials, and you may find some there. So thank you, and I am putting it on my list of topics that need additional discussion and research. Thank you.
Thanks, Anne. Any other questions? I think mainly aimed at the panelists. Take these three right here in this section.
Okay, thank you. I'm Pauline Mohoho from Intra Health on ESD project. Mine is a reaction to the lady who asked about documentation, if there's any literature, and also maybe a comment on something that Harriet presented. In Kenya, there is a program, a hospital program, where the community has actually become so sensitive to the integration part that in the MCH clinic, mothers coming for antenatal clinic, they expect and demand VCT at the same site. I think that is a step forward, and that they talk to each other about it. They ask each other, were you tested for HIV/AIDS? And it's something that should be promoted. Unfortunately, I'm not aware of any documentation on this. And that's among the AFIAs in Kenya. The other one is on the adolescent care. And there are two things. Adolescent mothers, when they go to the clinics in those two countries that you have studied, they are regarded as any other mother. No special attention is given to this. And I think this is an area of need, that this particular group you're talking of are a very special group. How do we stimulate the service providers to look at them as a special group and not just like any other mother coming to the clinic? I also want to share an experience we had in Uganda where you were working. I don't know whether your studies are part of, like in Jinja area, where we had developed adolescent-friendly services within the public sector facilities. It was a very big struggle. Some of the things you said today, we had it then. We had them then, like, for instance, the service providers will even report the adolescents to their mothers when they came with the STI, when they wanted a condom. And the service providers were regarding themselves as parents and censoring these adolescents. And a big job needs to be done. It's not just the knowledge of the rights. How do you change those providers' attitudes so that they can see these people as special groups, that they can respond to them, that they can talk to each other in the first place as people who are seeking services and service providers? In our case, the adolescents, when we were talking from it on a reproductive health journal, not HIV/AIDS, they were being thrown out of the clinic. And in the end, the adolescents designed what they considered adolescent-friendly services, and they were offered as such. And in the end, even the parents were demanding that that facility remain and the services be offered. So it's just offering some information.
Thank you. Let's take a couple more questions.
Hi, my name is Sarah Reese. I'm from ICAP at Columbia University. My question is for Michele Moloney-Kitts. You had talked a bit about one of the areas of possibility for integration around PMTCT and safe motherhood, and I was wondering if you knew of any case studies or examples of really where those two things have been really integrated and not necessarily just occurring at the same facility, but truly integrated. Thanks.
And then there was one more against I think, let's take this one up here first. Thanks.
Hi, Katie Porter with CARE. I wondered also, Michele, if you could talk a little bit about what hindrances you're seeing to integration based on the funding disparities coming in for MCH and family planning compared with that of HIV/AIDS. Thanks.
Okay, and I think Claude also had a question you wanted to pose.
Yeah,
Go ahead.
I would like actually to, my question is more or less related to the last one. I just wanted, Michele, if you could comment on, during my presentation I did mention cases where when you have specific funding you can't actually use it for other things. I was just wondering, with the new PEPFAR strategy, if you see the possibility of, let's say, covering non-HIV commodities with PEPFAR funding. Could you please comment on that?
Okay. Harriet, did you have anything you wanted to add to any of those questions?
No, I think those were useful comments.
Okay, great. Why don't we turn it over to Michele?
Yeah, thank you. And thank you also for your intervention. I do think that critical to this issue of adolescents is having them. In fact, the question I wanted to ask you was, what do those children feel that they need to be able to get the services they want? And I think that's the question we just have to asking people who are not accessing services. Why aren't you, and what do you need, and how can we design them better? Along those lines, getting to the question of where we've really had strong integration of emergency obstetric care and neonatal resuscitation, the overall package, together with HIV services. I actually don't know of that, and I am desperate to hear more and more and more that it's happening. And I would like to know, from where I sit, what you see as the barriers to being able to do that. And I really hope that the Global Health Initiative is going to provide the platform where that's so. I mean, actually, for me, it's been a source of real frustration because it's quite obvious that one would do that, and I don't exactly understand why it's not happening. And so certainly for those of you who are from organizations that have kind of a joint mandate in those areas, I mean, I would love to talk to you more about how we can better enable that from a policy perspective, because I think it's something that's hugely important to not only PEPFAR and the administration, but frankly to Michele personally. So however we can move that agenda forward, would love to hear. In terms of funding disparities, I think, quite obviously we all know that HIV/AIDS in terms of funding levels is hugely disproportionate to other U.S. government funding streams for other areas. That being said, we still have a huge unmet need for HIV as well as many other things. And again, we're hoping that under the Global Health Initiative, we're going to be able to take a look at some of these, the ways that we work together. Whether the administration is going to look with Congress and the Hill at the way funding is allocated, I think that remains to be seen. I think for those of you who know Congress at all and the history of foreign assistance, that's not an easy task to do. I actually prefer to look at what we can do today within these existing constraints, and I think we can do so much more than we're currently doing, and I'm hoping that whatever we can do from our position to enable that from a policy perspective, we will. In terms of the very specific question about whether we can use HIV funding to buy contraceptive commodities, that policy has not changed at the moment. In other words, we cannot use PEPFAR funds to buy contraceptives other than condoms, of course, and female condoms. However, that is a policy that is currently under review. So that's, I think, about as much as I can say at the moment.
And I think we've got time for a couple more. Why don't we take, there's one more right there.
Mariana Beta-Benke, USAID, Office of Population. A quick comment. I know with the topic with respect to PMTCT, ANC, family planning, postpartum care, I believe, if I'm not mistaken, the AIDS supplement that's on display out there and is also available on the HIV and SRH.org website. You can access the supplement through there. Has one or two articles on this topic. I also suggest you look at, I think it's a Studies in Family Planning, September 2009. The Vernon issue has an excellent commentary on family planning and the postpartum period. USAID recognizes that this is a big gap in the literature. It came up last year in 2008 when we had the Family Planning HIV conference with WHO and USAID chairing the meeting here in Washington, and that was a major articulation of a gap that's in the research, and we have we're in the process now of discussing with some of our partners how best to bridge this necessity. USAID is also in the process of having a Cochrane done on this specific topic, FP, MNCH, and HIV, which will be ready more or less around April.
And then the last, let's take the right next to you there, Dan, and right across the table.
It'll be quick, thanks. Natasha Sokolsky, International HIV/AIDS Alliance. Just a quick point of clarification, Michele. When you say it's a policy that's under review, what does that mean? Is it in the PEPFAR legislation or is it somewhere else? I just don't know. Thanks.
That's a very good question because I can't remember exactly what is in the legislation. But I do know that this is a policy issue that is under review at the highest levels of the State Department and NSC.
And then just across the table there.
Thank you to the panelists. My name is Godfrey Sikipa. I work for Management Sciences for Health. Just wanted to congratulate Harriet and her group for coming up with guidelines for health workers on how to handle adolescents with the reproductive health problems. I think much of the unfriendliness that we see from health workers or among health workers stems out of, first of all, ignorance about the need of these kids, and also lack of skills and knowledge on how to deal with the patient that's sitting in front of them. And to some extent, I believe we are probably all guilty of it. MSH is implementing a project in eastern Uganda in some 9 districts, and one of the cadre of worker that we have introduced in Health Center 3s and Health Center 4s is what we are calling a case manager. This is by and large HIV positive people. The approach that we have taken is we'll have 2 case managers per health center, and this will be a man and a woman. But listening to Harriet, I realized that perhaps we should have 3. Another one, a youth. And I think this is something that we're going to take from this presentation.
Thank you. And one last question here. Rachel here.
Thank you. My name is Kate Fleming. I'm from the American Institutes for Research, and I want to thank the panelists for bringing, again, to light what a lot of the people in the room have been talking about for a while. My question, though, is where are women with disabilities in the HIV and sexual and reproductive health and maternal health service discussion? The WHO estimates that 10% of the population is disabled, and what little small-scale research exists on the country level, it's 8 to 15%. But disabled women are assumed to be asexual and are either overtly or covertly denied access to HIV, sexual and reproductive health education, as well as maternal and child health, PMT, CT services, and the like. And so I guess I just sort of wonder, we can't achieve these lofty international goals if we don't mainstream disability, women with disabilities into HIV and sexual and reproductive health. So for both Claude and Harriet, have you done any looking or inclusion of women with disabilities? And for Michele, women with disabilities in HIV and SRH? Mm-hmm. Thank you.
And actually, just one more here with Rachel.
Just a quick question. I'm Rachel Seelig with UNFPA. This is for Harriet. I know that the age 15 to 19 can be really awkward. Even within this room, half the people referred to them as children and half the people referred to them as adults or young adults. So I understand where the awkward interaction with them, and it can sometimes be perceived as looking down on them or not respecting their rights. So have you thought of plugging into people who already work with that age group, whether through sports or through school or through trusted adults in the community who won't look down on them as children or without rights? Just a quick question.
Okay, we got a bunch of questions there and not a lot of time. If we can have maybe some rapid fire responses.
Yeah, on the question about disability, I have to confess that I don't have actually personal experience working with people with disability in general, and specifically with women. But I do know that in some countries, actually, there are some efforts. I know in Ghana, for example, there are a few groups that have organized themselves actually to really speak for themselves, to make sure actually that they are taken into account as we plan our responses. But again, I don't have first-hand experience with that topic. It's certainly an important area of work in which all of us would need actually to pay attention.
I can speak to the disability question. Obviously, huge need, very underserved, and thank you for raising it. In PEPFAR, we actually do fund a number of organizations that specifically reach out to the disabled. It's not targeted specifically to women and the linkage with reproductive health, but it is related to HIV and disabilities and making sure a particular population that I know we've done some really amazing work with actually is the deaf. But there is much, much, much more to be done, and I appreciate the targeting.
Regarding disability and maternal health, we haven't, unfortunately, the Population Council hasn't done work around that group, even though we do recognize that this is a special group that needs special attention. Regarding interventions that are really outside the health setting for young people, I think it's really important that we go out into schools, for instance. But what we've realized is that the school environment across many of the African countries is not really prepared for HIV-positive young people. We've done a study in school. I brought some reports and put them on the shelf. And what we realized is that schools, the education sector is now actually grappling with the whole issue of making education more inclusive for young people who are living with HIV. We've gone to schools where they have signposts that this is an HIV-free zone, and yet we have 70% of HIV-positive young people in school. The message in school is about preventing HIV, so it's targeting those who are not HIV-positive, but nothing is being done for those who are HIV-positive. Also, what we realize is that disclosure within the school environment is extremely low, because what has happened is that the school nurses act like policewomen and men, reporting on those who are HIV positive so that they are thrown out of the school. So it's a very explosive environment. So we're trying to see how we can work with the education sector so that they can offer comprehensive information and services, and so that schooling is more inclusive, because people who are living with HIV, young people who are living with HIV, need to be in school if we are going to reduce on maternal pregnancies, unwanted pregnancies for them. And they want to be in school because that's the best way to make friendship and also to get access to information that they desire to have. We've also worked with support groups for young people who are living with HIV, and those sometimes they're very efficient and sometimes they're not. What we've realized is that many of the faith-based organizations had set up support groups for young people who are living with HIV, but the messages are very boring. Normally they come in and sing church music and almost like preparing them for death. It's not really like... So the groups they had a lot of membership in the very beginning, but the membership started going down because they were not really addressing the needs of young people. They were not really talking about the things that young people really wanted to hear. They wanted to hear about issues of dating, how do you go about it, how do you deal with this identity of being HIV positive. But still programs were still drawn on HIV as death, talking about preparing wills, all sorts of funny things. So we need to again work with these groups and see that we bring life into these groups so that they can carry the right message and a positive message to young people who are living with HIV. Yeah, thank you.
Okay. Well, thank you all so much for so many great questions. I know there's a lot more, so perhaps can get people afterwards. But thank you all so much for coming. And we look forward to seeing you at future events in this series. Thanks so much.